Hello everybody, it's Dr. Ermias here with another video. Thank you for watching my videos and subscribing to my YouTube channel, Smart Hospitalist. I've started making videos to challenge some of the outdated practices that we still do in hospital medicine. Continuing with the same theme, today I come to you with a very important topic, in my opinion. It's regarding contrast-induced kidney injury. Is it real or myth? This sounds familiar, right? You have a patient who needs a CT chest with contrast, for example, a CTPE study. You have a high index of suspicion for PE, but the creatinine is 1.8. Would you still go ahead and order the CAT scan, or would you forego the CAT scan because of the elevated creatinine and possible kidney injury and go for some tests like the VQ scan, which practically does not usually happen? All right, so let's look at the evidence. So for decades, we've been told that IV contrast causes AKI, and everybody is like always afraid of giving contrast in patients with kidney disease, right? And there's this term called contrast-induced nephropathy became like gospel, like a dogma, and patients often miss the life-saving scans just because of this. But the risk of acute kidney injury, developing in patients who receive contrast has been overstated in these old studies, which kind of told us that contrast is bad for the kidneys. These studies are old, and predominantly they were done in patients who received intra-arterial contrast, especially during long procedures like coronary angiograms and percutaneous interventions. The type of contrast used was also a high osmolar contrast mostly, and a high volume of the contrast was also used. In addition to this, these studies did not have a control group. So it was very difficult to deduce that these patients who received the contrast had AKI because of the contrast, because there was no control group that did not receive the contrast to compare, because this could easily be confounded by other factors that can cause kidney injury. So newer studies tell a different story. There are different like meta-analyses comparing patients who received contrast CTs versus control groups, those who did not get the contrast. They did not seem to show any consistent increase in AKI in those patients who received the contrast. In fact, most of what we thought was contrast nephropathy was likely due to underlying illness, sepsis, hemodynamic instability, including hypotension, or other nephrotoxic medications contributing to the AKI rather than the contrast itself. Therefore, this necessitated a change in the terminology. So now we do not use the term contrast-induced AKI for every creatinine elevation that occurs after a contrast administration, because there is no convincing evidence that the contrast itself is toxic to the kidneys. So we use the term contrast-associated AKI, which is kind of inclusive. I mean, and saying that it could be the contrast, but also there are probably other factors involved in the progression of the kidney injury. So the American College of Radiology has come up with a consensus statement and recommendations as to how we approach contrast-associated acute kidney injury. So they say that there is very little evidence that IV iodinated contrast material is an independent risk factor for acute kidney injury in patients with eGFR greater than 30 ml per minute per 1.73 meter square surface area, right? So in those patients with creatinine GFR above 30, usually the risk of contrast-associated AKI is pretty much non-existent. In those patients with eGFR less than 30 and some other concomitant risk factors, including diabetes, with diabetes, it might go up to like 45. There is possible risk. So I mean, they are not saying that there is no risk with contrast at all, but the risk has been overstated. And we should not be afraid of using contrast in these patients. So they emphasize that there is no absolute threshold of serum creatinine or eGFR where contrast should never be administered. So there's no absolute contraindication. Each case requires individual analysis of the risks and the benefits. So how about for those patients who are at high risk, like with eGFR less than 30, like chronic kidney disease with eGFR less than 30, or rapidly evolving like acute kidney injury who are not on dialysis? Then they recommend, if it is possible, to make a diagnosis with other imaging modalities that does not require contrast, go ahead and use them. If contrast-enhanced CAT scan is deemed necessary for the diagnosis and the benefit is higher than the risk, then you're better off using standard contrast dosing rather than low volume dosing, especially for imaging studies with IV contrast, because you might get suboptimal image and you might not be able to make your diagnosis. So it's better just to use the standard contrast dosing. Um, And how about on those patients who are anuric on dialysis? Is there any risk of using the contrast? Not really, right? Because they don't make urine, the kidneys are not working, and these patients can get contrast anytime, any day. And you do not need to prophylactically dialyze these patients or dialyze them right after the contrast. They can continue with their usual dialysis sessions. That was from the American College of Radiology. And how about from a nephrologist's perspective? That was from a radiologist's perspective, right? So you might think that, it's radiologists, maybe they don't care too much about the kidneys, right? But I have these recommendations from the nephrologists, from the KidGO guidelines. So what do they say? They say medically necessary contrast-enhanced scans should not be avoided solely based on perceived AKI risk. So again, this goes hand in hand with the College of Radiology's recommendation as to saying that there is no absolute contraindication based on the kidney function. So the KidGO guidelines recommend pre-hydration in patients with eGFR less than 30. In general, they recommend certain risk mitigation strategies if you're using contrast in patients with GFR less than 30 or in those patients with rapidly evolving AKIs. So some of the risk mitigation strategies are like to use low osmolar or isoosmolar contrast media rather than high osmolar. I think nowadays almost everywhere people use low osmolality or isoosmolar contrast medias. And also they say to use less contrast volume. Mind you, this is not for patients who are undergoing IV contrast injection for CAT scans. This is probably for patients who are using a higher volume studies like coronary angiograms and PCIs as much as possible to limit the volume of the contrast in those scenarios, and withdrawing potentially nephrotoxic medications like NSAIDs, diuretics, and so forth for 24, 48 hours before and after the contrast exposure. And also they recommend the use of prophylactic IV hydration if there is no contraindications to volume expansion in those patients with the eGFR of less than 30. Diabetic patients, the contrast-associated AKI risk starts to be seen with eGFR of 45 rather than 30 in those patients without diabetes. So you got to be careful in patients with diabetes and kidney disease. Traditionally, metformin has been recommended to be held like 48 hours before the contrast administration, but again, this is only in those patients with GFR less than 30. In those patients with GFR above 30 and diabetics, again, it is the metformin can be continued. There's no issue there. But if the GFR is less than 30, then you better hold it during the day of the contrast administration and can restart it after 48 hours if the kidney function remains stable. There are a couple of prehydration protocols, right? There are different ones. The typical prophylaxis regimen starts 1 hour before contrast administration and then can be continued up 3 to 12 hours afterwards, depending on uh, the risk, right? So the dosing may be fixed or it could be weight based. You can give like 500 ml normal saline starting 1 hour before contrast administration, continue to 3 to 4 hours. If the patient is undergoing more contrast intensive studies like coronary angiograms, PCIs, or are there at a very high risk, then more aggressive hydration protocols can be undertaken. This one like prolonged 12 hours before and up to 24 hours after the procedure with 1 to 1.5 ml per kg per hour of normal saline can be used. But is there an evidence that prehydration decreases the risk of AKI? Again, this is mostly based on theoretical basis. I mean, we know that intravenous sodium bicarbonate does not offer any benefits over isotonic sodium chloride, normal saline. This has been proven, so we do not use sodium bicarbonate. But how about just the use of prehydration? There were some studies which also questioned that. The amazing trial showed there was no significant difference in AKI incidence between people who underwent prehydration versus no IV hydration. Also, there was another study called the COMPASS study, which showed, withholding prehydration was non-inferior to sodium bicarbonate prehydration. So again, this is theoretical. Essentially, the reason why we use hydration and expand the intravascular volume is to, increase the kidney perfusion and limit the amount of time that the contrast stays in the kidneys. Therefore, that would prevent the perceived contrast toxicity to the tubules, which again is really not proven. So the problem with these two studies was that they were done only in stable patients. They were not done in the outpatient setting. They were not done in patients who are admitted in the hospital in the acute care setting. So it might not be generalized to admitted patients. But they are saying that oral hydrations may be sufficient in these patients. Again, we need more studies on this, and this is not really proven. Until it's disproven, we will continue to use a hydration protocol in patients who are at high risk for contrast-associated AKI. So bottom line is, don't withhold necessary imaging for your patients just because of a borderline creatinine. You got to be cautious in very high-risk patients. Advanced CKD with eGFR less than 30, a rapidly evolving AKI, multiple other hits to the kidney. You got to be cautious, and you have to use your hydration protocols. But mind you, missing a diagnosis is often more dangerous than the risk of contrast-associated kidney injury. So the current evidence is kind of channeling towards saying that contrast-induced kidney injury is probably more of a myth than a reality. It's definitely overstated in the previous studies. Most of the kidney injury that occurs after contrast administration is probably not due to the contrast, and it's probably due to other associated risk factors in the acutely sick patients. So if you need the CAT scan with contrast to make your diagnosis, please go ahead and order it. Do not hold back because of fear of contrast-induced kidney injury. If you like the contents of this video, please go ahead and hit the like and subscribe button. If you have any comments, questions, I will be happy to read them in the comment sections and get back to you. Until my next video, have a good time.